Hi, good day everyone. And so we will continue this presentation, and I would like you to bring still where we are at in the topic of our discussion. We will be now doing pharmacologic management of mood disorder, and this time we'll focus on bipolar. If you remember from previous presentation and posting, we were starting at mood disorders, although I incorporated and introduced anxiety first. It was followed by depression. So that's where we are in the mood disorder. I have given you in a separate recording about depression. This time we are still in the mood disorder, and we are now in the bipolar. Know that in the mood disorders, the major depressive disorders is actually your unipolar disorder. And so this is the other side and the other spectrum of the mood disorder, which is basically your bipolar disorder. So this is where we're going to focus our discussion this time. I want you to know that your mood stabilis knowing about the mood disorder, it is actually a natural extension to the discussion of depressions. I've said because it's the unipolar part, and this one is the bipolar spectrum mood disorder. We now need to consider the rest of the mood spectrum, which would bring us to the bipolar, the ups and the down moods. Understanding the circuitry of the up mood or mania is much less precise. Unlike your understanding with anxiety and the unipolar major depressive disorder, your mania is less precise, meaning uh, those anxiety and depression has a strong correlation with um, the circuitry and the neurons and neurotransmitter, such as the lack of serotonin, lack of norepinephrine and dopamine in the case of anxiety and depression. But in your mood disorders, and specifically bipolar and that of the mania, it's less precise as to where and what is really the background and where's the cause of it. There are some possibilities, different parts of the brain I will discuss later on, but it's not so strongly correlated to those reasons and circuitry. So it's kind of ambiguous why there is mania. Another thing too is that, as I've said, the circuitry of up mood or mania is not intuitive. It's not straightforward. Unlike anxiety, it has an influence with your, aside from neurotransmission, the amygdala, the loops that we discussed earlier. Mood stabilization is kind of vague. Mania is not precisely the opposite of depression from a circuit perspective. It's not that if you are depressed, you're manic, or if you're manic, you're not depressed. Well, there are a lot of individual that's actually having the mix, not necessarily either they're depressed or mania. They felt it all together. That people in the bipolar spectrum may be talking a lot, very hyperactive, but at the same time feeling depressed and down, hopeless and worthless. They happen at the same time. So that's the reason why if you look at your DSM-5 criteria, if you remember, your DSM-5 criteria, which I want you to be very, very familiar, because that is your, I would say, the Bible for diagnosing somebody. Follow the criteria, document the way the criteria is being defined, and you'll be very, very safe and be guided to identify your diagnosis. But if you look at that DSM-5 diagnosis, you will remember that aside from major depressive disorder and bipolar disorder, there is a gray point in the middle. There is what we call as mood disorder, not other specified. And that is part of the criteria of DSM-5, where individual, you cannot identify them only as either polarizing, either depressed or manic, or having mood swings. They have signs and symptoms of each one, and they're ambiguous that you cannot identify. I think another factor too is age. We established that the brain develops from front to back, and then it takes about at least the age of 18 to 21 that many of the brain functions are well established. So individual who manifest some mood spectrum, depression, anger, anxiety, or mood ups and down mood swings, while they are in their younger age before 18, before the brain is fully developed, sometimes a lot of clinicians felt so uncomfortable in diagnosing them with bipolar. So then they put them into this gray area of mood disorder, not other ones specified. Well, that's just to show that mania is not precisely the opposite of depression from a circuitry perspective. Um, Patient uh, can be both manic and depressed at the same time. So let me share with you some input and some sharing coming from another great clinician, Dr. Sally Miller, um, who happens to be uh, sharing a practice with me as a private practice, but at the same time, um, when she was, after all her accolades of being a family nurse practitioner, pediatric nurse practitioner, and so on, she decided to be an PMHNP. So we were together in the practice, in my practice, where I was helping and guiding her as her preceptor, and she made it very clearly and share her experience. And this sharing and experience that she narrated here is actually showing that patients can be both manic and depressed at the same time. Let me share with you from a perspective of being when she was a student and how she remembers, the importance of interaction and the importance of observation, not just basically knowing the background right away, in order to identify the mood of an individual. So let me see and try to play with this, and I will try to share this with you. Hold on.
Can be both manic and depressed at the same time. And I wish that I could explain that to you clearly in really concise terms. I mean, I'm one of those very concrete thinkers. I like things to all make absolutely perfect sense. I am columns and lines and brick and concrete and foundation. And when it comes to mood disorders, it's just not that straightforward. Patients can be both manic and depressed at the same time. And I'll tell you, I remember so clearly one of my very first days in my clinical experience in my psych mental health program. I was still, it was like the first day or the first 2 days, I was still observing with the preceptor. So we're sitting in the office together, and this woman comes in, and I did not look at charts that early on because he didn't want me to get any preconceived ideas. You want me to get stuck on the concept of anchoring, like if they have this diagnosis, it must be it. He wanted me to just take things at face value from the patient interaction. So this patient comes in, and she sits down and starts talking, and then she starts crying, and she clearly is depressed, and she's giving all of the symptomatology for depression, and yet she looks so put together. Like her her purse matched her hairpiece and her earrings and her nail polish, and it was like there was this aquamarine sort of fairly bright greenish blue thing going on, and she had some sparklies in her hair, and her makeup was extremely well put together. And when she left the room, I said to him, she looks pretty well put together for somebody who's depressed. I wish I could get myself together that well. And he looked at me and he laughed, and he said, she's bipolar. She's bipolar. The up end of her mood manifestation is this extreme precision and bright colors that all match in her appearance, and the down end was evident by the way she talked to us. And I never forgot that. I also then, every time I was getting dressed to go to clinical, I tried to be very aware of not being too bright or matching up too close or anything, because I didn't want people to think I was bipolar. But I never forgot that. And it really was a good lesson in paying attention to both how people look and what they say. And as I came to know this patient, because I spent a long time in that practice, and now I work there 1 day a week, so I've known these patients now for a few years. This lady, when she is excuse me, when she is well managed and her her drug therapy is really optimized and she's compliant with it, she does not dress that precisely. I mean, she looks fine, she looks totally fine, but she's not all about everything just matching precisely, and having a headpiece and a bracelet and necklace that matches her nail polish, that matches her handbag and her shoes and all of that. And I just never forgot that. So, I mean, I try not to think of every patient who matches as being bipolar, but you get what I'm talking about, right? People can truly be both manic and depressed at the same time.
So I hope you learned from that, Dr. Miller's example and sharing with what what she experienced during one of our interaction during her PMHNP student life, so that you get the whole perspective that patients can be both manic and depressed at the same time, and you cannot just precisely identify that mania is precisely the opposite of depression from a certain perspective. And even in clinical perspective, they may show some mix. So if you also remember your spectrum of types of bipolar in your mood disorder spectrum, there are who we call as mixed type, where they felt the depression and that yet they manifest the the mania part. There is also the cyclical, that 3 days, 4 days, few hours, that they go up and down with their manic and depression. And then you have, of course, bipolar 2, which is more majority than your bipolar 1, the bipolar 1 being the extremes, depressed and manic. Your bipolar 2 is mostly depressed and some period of hypomania are also there. So that's just a quick review of what you have learned before already, what are the different types of bipolar. Okay. So, so talking about mood stabilization, that is understanding the neurotransmitter are very implicit also in mania. You know, although they are not exactly the opposite of depression, we would like to have certain some point wherein we could start to understand, objectively, that neurotransmitter are also still very influential with mania. So we're talking about your norepinephrine and dopamine. They are also excitatory, so therefore trying to stabilize and control its abundance, perhaps at the point of the receptor area, or perhaps the decrease, or the increase of reuptakes, and the destruction can also cause an up downs of mood with this neurotransmitter. But very also important, aside from your norepinephrine and dopamine, who are the excitatory, is your glutamate. Glutamate is a more prominent in the up mood in this mood disorder spectrum. In fact, glutamate is the primary excitatory neurotransmitter in the brain that can influence mania, or the up mood, if we have to say. So consider also norepinephrine and dopamine at the same time. This primary excitatory neurotransmitter in the brain that can influence mania is your glutamate. So that's one of the important neurotransmitter consideration that is affecting mania, if you have to start with. Well, it's also very important, again, as I've said, to understand the function of this neurotransmitter, because this is upon which you should reflect your medication management in trying to make a decision which one or which medication you would like to use in order to stabilize the mood and to balance out this neurotransmitter. Many of the functional centers also on the pathway is very closely related or implicit in mania, and which is the same as depression. So if you remember, we were talking about the amygdala. The amygdala, which is the centers of fear, anxiety, aggressions, memory, decision making, and some motor response, if you remember that during our previous discussion. These are also still have some influence. These pathways has influence in the mania. So it could be the amygdala that increases that fear and the anxiety of the bipolar somehow sometime in their symptoms. And also remember also the prefrontal cortex part of the brain, and which is responsible for your worry and depression. So this could be either of this part of the brain that acts more, or the lack of that makes the person goes feeling up and down. Of course, you have your hypothalamus and your thalamus, which is basically the command center of the central nervous system, or it's the command central area of the nervous system. So it's acting out, or the lack of its stimulation can also be one of the psychopathology behind the patient's mood swings. And then you have, and you remember your stratum loop, the loop that we have discussed during anxiety, the CSTC loop. So these are responsible for the feelings of being apprehensive, misery, catastrophic thinking, which is also affected during anxiety, recurrent thoughts, obsession. So that's why a person who's also in their manic phase have all certain thoughts of obsession, and rumination. So if you could remember too, so as a multifactorial parts of the brain, aside from neurotransmitter, your norepinephrine, dopamine, as what we've said, are excitatory, plus your glutamate, which is the major excitatory part of the brain that can be affecting mania. You also have these other pathways that can be affected during mania. So you have the amygdala, the frontal cortex, of course your hypothalamus and thalamus, and your loop. Okay? So those are some of the structural and functional parts of your central nervous system that may have influence over manic symptoms. Well, so the physiology is best described as imbalanced or out of tune. So all of these factors of the brain, along with your neurotransmitter, might have give and take, ups and downs on their functions, and thus create that imbalance. And then you have that concept of being out of tune, which is then your mood swings. So pharmacotherapy is designed to stabilize this monoamine regulation, as it is in depression. It is also still very evident in understanding and management your mood disorder. So pharmacology there is designed to stabilize also this monoamine regulation, your norepinephrine, your dopamine, basically your glutamate. The science of mood stabilization is one of the most poorly understood though. Although we have identified perhaps parts of the brain that may contribute to the ups and downs and the bipolarism, the depression, and the mania symptoms of the patient, still the mood stabilization concept is one of the most poorly understood. Sometimes people, even physiologists, clinical physiologists still probably continue to understand and do research, but a lot of the clinicians also, though it's poorly understood and well understood, they function in a way that they also try to match manifestations and minimize symptoms by the use of what knowledge we have with medication. Okay? So there's also this research plus clinical expertise, clinical practice, and clinical experience that kicks in, although the exact science might still be poorly understood. So it's clinically treated also. Well, regardless of the precision with which we understand, we know that certain drugs clearly reduce mania. So when we say certain drugs clearly reduce mania, these are then, which we discuss later on, the medication that can be best used to control mania. So we call them mania-minded. Of course, in the other end, there are others that would improve depressive symptoms, and then we call them depressive-minded medication. So those are things that in clinical practice you need to know, and also you need to observe, and that builds up your experience. So there are medications that are indicated for bipolar, but then experience-wise you notice that using this medication is best because they are indicated for depression type of bipolar, so they are your depressive-minded medication. So after you or in the other end, that certain drugs reduce mania, they're your manic minded medication. So while you're doing your assessment, you're doing your history taking perhaps, and then your assessment, you want to make sure that you zero in as to what is the majority of the symptoms manifested by this patient. So if you notice that this patient has more manic episode than depressed, then you probably would favor those manic-minded medication. But if during assessment you notice their theme is mostly depressed, there are periods of hypomania or mania, but very seldom, but most of the time they are mostly depressed, then you may probably think of using medications that are depressive-minded. Okay, so this medication can reduce acute symptoms, either manic or depressed, and then they can also be used to stabilize mania and or depression. So they improve the symptoms and they prevent relapse. But you just want to match the characteristic and what is known about the medication as well as its action to the patient that you're actually assessing. Well, not all probably. You might have 2, 3, 4, 5 or more patients that are diagnosed with bipolar, but each one have their own unique characteristic. You know, some are mostly manic, some are mostly depressed. So that's how you should mix them up. Uh, Let me see. Well, another concept is that not all drugs used to treat bipolar disorder are appropriate at all points to a bipolar spectrum. So some drugs are very appropriate for acute management, but not very appropriate for chronic or vice versa. So I want you to know that, like such for example, later on we'll talk about lithium. Lithium is a type of drug that is very appropriate in acute management of mania or perhaps suicidal ideation. But then as you control that symptoms of what they are presenting, such as you control the mania, you control the suicidal thoughts, then you would like to have a long time management, then you probably would try to switch it to another type of medication, because then these type of medications like lithium perhaps, because then later on you will know that lithium have a very narrow therapeutic level and it can increase the risk for toxicity. So while they're really good at any point of the bipolar spectrum during acute mania or suicidal thoughts, once those gone, you could probably be the clinician to decide, okay, let's switch to another mood stabilizer that are fairly safer than continue the lithium. You know, well, I gotta tell you, some of which also don't have any other choice. The only medication they have to respond on is perhaps the lithium. And that's just something that you need to know about the characteristic of medication. Again, I think I mentioned it from before. What you gain in safety, you may probably lose in efficacy. So like for example, in that statement, lithium is very efficacious in times of certain acute symptoms of mania and suicide ideation, but then they're also very high risk for your side effects and even therapeutic and lethal, you know, toxicity. So appropriate selection is considered in acute symptoms at the time of presentation as well as history of cycling. So you need to know really your patient. You know, you really need to know your patient. Are they manifesting their acute symptoms, and what medication can I utilize to control these acute symptoms? What is going on with this patient's history? Are they showing their cycle history or history of cycling? And you just have to match them. It seems like I missed part of the other slide. Let me go back. We talk about those. Yeah, we talk about medication that are certainly manic-minded and medication that are depressed-minded. I just want to add more that we want people to have feelings and feel certain mood. You know, because while that being said, there are medication that controls mania and there are medication that control depression, but we don't want them to feel stoic. We don't want them to feel blunt. We don't want them to feel flat. You know, we want them to feel certain mood, and we don't want them to have a very flat or stable mood throughout. Well, there are times, based on my experience, there are a lot of bipolars who, again, are misdiagnosed with depression, treated like depression, takes 8 to 10 years before they're actually identified bipolar, because they only talk how depressed they are. And then you starting to identify them finally that they're bipolar, you give them certain mood stabilizer, and then they don't comply. Why? And that's always the case. They don't comply because they feel like they're blunted. They're feeling that they're so flat that they don't have excitement or what they call as creativity, which are their hypomania or manic stage that they never talk about because they love it. And then you finally pick it up and put them on a mood stabilizer, but the mood stabilizer is actually so very stoic for them that it brings their mood in a flat mood. Okay, of course, obviously we don't want them to have all mood swing that will interfere. That's the key word. We don't want them also to have these mood swings that will interfere social and occupational functioning, but we want them to feel good or feel good when the situation calls for it, and we want them to feel down about a real situation that makes them feel sad. We don't want them to flat and stable. So that's the reason why, although we want to use medication based on their presentation, we would like also to balance it out. We don't want them to have that perfect steady state of mood. That is the goal of the medication therapy, is to decrease the extremes, but allow them to feel, what normal people would feel. So that's the reason why we do symptom control. So therefore, some drugs is more manic-minded, they control more manic symptoms, and some drugs are more depressed-minded, they control the depression symptoms part of the spectrum. But always listen to your patient, though, you know. But because if you probably using a manic-minded medication, like as I've said in the previous slides, lithium, then it's at control with, as it controls the lithium but makes them flat. I mean, as it controls the mania but it makes them flat, then probably time to switch also to a steady or a maintenance type of medication that is also more safer. That's the context, or that's the context that I would like to share with you. So still talking about mood stabilization, antidepressant are not routinely indicated as the first line of management of your bipolar disorder. I think I've described with you also before, that it takes, or you should take some time and expand on asking history and assessment to symptoms that may not be readily presented to your patient but could be potentially happening, but the patient is just not identifying them. So a well-rounded history taking should be done. Like, even if the patient comes in with a chief complaint of how depressed they are, they're suicidal, always find time to look at the opposite or the other side of the mood. Although it's not the presenting part, it's good to always listen to the presenting part and focus, but always have that review of other mental health problems and symptoms. Always expound it, because that's again the problem in treating bipolars, is that a lot of clinicians, of course, a lot of patients would only tell what they don't want, and that's depression, and then a lot of clinicians don't expound the whole thing. So even when the patient is in a depressive episode, always ask about, were there times in your life that you felt so high, you felt so excited, you felt so motivated and elated, not only happy, but elated, or higher than being well-being of being happy, if not even euphoric, out of you become Superman, or you felt like invincible, ask those one moment, twice in a lifetime, can be a telltale signs that it's not only what's presented as a depressed. So then you got to think that routinely the first line of bipolar, with your good assessment and history taking and a good diagnosis skill, antidepressant is not the first line. Why? Again, this is the problem many of the clinicians would fall, especially in primary care. That's the reason why it takes 8 to 10 years before they're properly diagnosed. Well, there are also cocktails advocated for mood disorder that includes antidepressant. Don't get me wrong. As you know your patient really well, and then you try to manage symptoms of decreasing the hypomania or the mania, as well as increasing the mood. I mean, you may find yourself combining medication. You may combine medication, form your own cocktail where you have a lower dose of an antidepressant, but mostly only incorporated when you have at least certain level of mood stabilization from a mood stabilizing agent or a mood stabilizer, and then you incorporate a little of those. Like for example, Celexa, it's indicated at 20 milligrams, but you notice after a while of using a mood stabilizer that stabilizes the mood, the patient is still have some melancholic episode, some sadness, low-lying depression. Then you may probably say, okay, it's indicated for adults at 20. I may probably give you a little dose of an SSRI just to boost your mood up, but I'm just gonna give you only 5 milligram or 10 milligram the most, so that it does not perk you up to be also in hypomanic or manic stage. So there could be some cocktail for mood disorder that may include antidepressant, but again, the bottom line is that antidepressant is not a first choice of your mood stabilization, because it can make them feel good for a while, but it does not sustain. It throw them up so manic and then drop down more depressed, and then all you got to do is try another, adjust more antidepressant, and you go into the cycle. But the key word here is proper diagnosis. You got to invest on your diagnostic skills. So let's go into discussion with some of the most common drugs, common medications that can be used in your bipolar. So one of which is lithium. Of course, lithium is the classic mood stabilizer. I gotta tell you, lithium is the classic mood stabilizer. Its mechanism of action is unknown, although there are a lot of clinical evidence and clinical accounts as to how lithium manage mood disorder. That's just the whole spectrum and gamut of this medication. Its mechanism of action is not known, but it's well respected to control certain aspect of your mood or your bipolar symptoms. And that's why lithium is considered as the gold standard. So it is the prototype drug to treat acute manic symptoms. That's the whole highlight of lithium, is that it is known to treat acute manic symptoms. It is the only drug that's indicated for bipolar disorder that clearly reduces suicidal ideation. So that's another advantage of lithium. I want you to remember that lithium is a very effective drug to control acute manic symptoms and that of suicidality. And the reduction of suicidality does not appear to be related to control of mania alone. It can control both mania and or suicidality too. Well, somehow perhaps in your experience, probably when you're going to your preceptor or when you become a PMHNP pretty soon, you will notice about how this medrep talks to you about the impact of their certain drugs and how it impacts, like for example, dopamine receptor. So they will bombard you with all this information. Oh, these drugs has a new indication, and this is the mechanism of action. They do convince you of how it controls for example, the dopamine receptor, or perhaps how it acts in glutamate mediation, that although glutamate is an excitatory, this would decrease the receptor part of absorption of glutamate, and thus it controls the manic symptoms. It seems like it's very, very clear. They will convince you. But if you read their handouts and you will read the fine prints, at the end it will say the impact of efficacy is still not clear. Well, the reality is that's true. We might know how it acts. We might know how, and they may probably have an extensive research on how they act or how the mechanism of action is. But the bottom line, the question is, how did it deliver to this patient the effect we want? The impact of efficacy is still not clear. Many drugs we know that affects the brain, and we understand how it can affect the brain, but the question is, does that produce the clinical outcome we like to achieve? It's not clear cut, you know. So lithium as the mechanism of action is not known, but it is still considered a gold standard of mania, because lithium, although the mechanism of action is not known, clinically we've seen that it treats mania. So that's the advantage of lithium. So that's something that experience and clinical perspective we can go by. Lithium is the medication that would stabilize the mood. But again, the problem for lithium is that it has a very narrow therapeutic level. Also in psychiatry, suicidality is a big factor that would shorten life expectancy. And lithium is one of the medication that reduces suicidality. So if lithium decreases suicidality, and in psychiatry, it's one of the big factor that will shorten life expectancy, that's why it is very important to recognize that this drug reduces that incidences of the risk, which is suicide. So that's another reason for you why you favor lithium. But again, that's just telling you how lithium works. We have a very good efficacy of lithium. The other side is that safety also can be very narrow. You know, it has a very narrow therapeutic level between therapeutic level and toxic level. So lithium is very useful for stabilizing mood after acute mania is managed, and lithium is extremely effective. However, its use is limited by serious adverse effect in its profile. Again, I've mentioned that it has a very narrow therapeutic margin, and thus requires a very frequent monitoring. Okay, that requires a very frequent monitoring. So the whole thing is, if you look at this picture, you've noticed that the therapeutic range of lithium is from 0.6 to 1.2 milliequivalent. So, you know, we would like to be there all in the middle, like 1 milliequivalent as a therapeutic range, and that would be very, very good. So then you notice, if you look at the toxicity level, you would like to maintain, while you are giving lithium, a result of at least, you know, maintenance therapy, you would like to be between 0.6 to 0.8 milliequivalents. For acute mania, you may probably would like to be at 1.0 to 1.2. That is still within the therapeutic range for acute mania, but you got to be very careful, because by 1.5 and greater, then starts the toxic level. So that's the reason why we say there is a very narrow margin of safety and therapeutic drug monitoring it's needed, especially for lithium. So it has a very, very narrow therapeutic and or your toxic level. So why not use lithium for all our bipolar patients? Well, the greater the efficacy of the drug, the more serious the side effects. That's the whole take with your lithium. Okay. Effectiveness, again, let me brought to you back again the discussion about effectiveness. Effectiveness, does it, the effectiveness should answer the question or of does it do what it says it will do? Yes, it does, especially in acute mania and suicidality. The efficacy would guide us how does it improve the outcome over its course of use. You know, if it's effective, what it says it does, and is it efficacious that it improves the outcome over its course of use. Okay? So let me share with you also that there are about two different thoughts as a clinician you should think. There are drugs that blocks dopamine receptor, but it produce the outcome of the patient. Well, it's not clear cut, you know. So you also have to consider that thoughts. Pharmacokinetics, if you remember, in the first part of, I mean, I think 794 in your end, and I put some just slides for you to review, also talks to you about minimally effective concentration. If you remember in your pharmacokinetics concept. So let me do a review a little bit with that one. What is minimally effective concentration, or MEC? And also, what is minimally toxic concentration? That is a very good concept that you could apply talking about lithium. You know, what is its minimal effective concentration and what is its minimal toxic concentration. So when we say MEC, minimally effective concentration, I want you to remember that every drug has to have that, and you must exceed a little of that drug in your serum for it to have its effect. That is your minimally effective concentration. You know, what the least dose and a little bit higher in that serum, in your blood, in the serum, to create its effect. So you have to look at that between understanding lithium toxic level. While that of the minimally toxic concentration is that's the point when the drug concentration in the serum is beyond the therapeutic level that it becomes toxic in the body. So looking at lithium level, you always would like to have your minimally, you would like to go and maintain that minimally effective concentration. So if you have 0.6, you probably would like to have that until 0.8 to 0.1, you know, because it can maintain, it's in the therapeutic therapy, and it can still control acute mania. That is your minimally effective concentration. A little bit beyond the lowest therapeutic level, a little bit higher there, but still within that limits. But be very mindful also about the minimal toxic concentration. In that way, you don't want to go beyond 1.2, because you know anything greater than 1.2 might now get into the toxic level, as you understand the narrow margin of safety. So therefore, while you dose the patient on the lithium, you know, you follow probably the guideline of what is the clinical dose for this. In this case, you know, if you're dealing with acute mania, it would tell you this is how many milligrams you should use to, and when you want to go into maintenance, drop it down. Well, the reason why you would like to do that, because you want to be respecting and following the concept of minimally effective concentration versus your minimally toxic concentration. So later on, you would know that there are certain dose that is required for acute mania, and then when you go into maintenance, you would like to drop it down to at least 900 milligrams per day of lithium. So you play around those doses while you also monitor the blood level. Well, you try to play around those, what you're trying to control, such as acute mania versus maintenance, because you would like to achieve what we call as the steady state. You know, so steady state needs to be contained that it's the level of concentration of the medication in the blood or in the serum that is a little bit above minimally effective concentration, but below the minimally toxic concentration. So that's the reason why you would like to be a little bit higher than 0.06, but also would like to be a little bit lesser than 1.2. So probably, 1 milli equivalent would actually do the job of that's what you like to achieve, and then look at how much medication you're using and maintain and adjust the dose. So that's how you make the decision in how to play around with lithium level at the same time your lithium dosage. Well, talking about MEC and MTC, there are many drugs that have wide range of MEC and MTC. So we are concerned, we're not so concerned if the range is so wide, we're not so concerned about the toxicity because we have a lot of leeway to play around. But lithium is not that way. It has very narrow. You could just see that its therapeutic range is 0.6, so you would like to be a little bit higher in your MEC there, but its higher end is 1.2. Greater than 1.2 is already a toxic level, so you want to be a little bit lesser than also there. As I said, other medication can be later on, carbamazepine, Tegretol level are having wide range, so that's why we're not so concerned about the toxicity, although we still have to monitor. But lithium is an exception. We want to be extra careful. Lithium is one of those that has a very narrow range, as I've said. If you could read your Stiles book, and review the lithium level to be sure, and also add more information. Keep the level of lithium in the serum as we need to maintain a consistent dosing. The problem is that patient who takes medication regularly and may somehow start to question, and then it can affect their compliance. Know that not all patients in psychiatry are known for their adherence to their medication regimen. They may start very good in their compliance, but as they start to feel, and I've seen this in many of my bipolar patients, they get stabilized and then it's really good. You see them now regularly every 3 to 6 months or every 3 months in my case. I rather see them every 3 months. You notice that somehow into the year or more than a year, they start questioning, do I really need this medication? I feel normal. They have to realize they start feeling normal, and they are feeling normal because they're on medication. But sad to say, many of them would experiment. They start missing one dose, one day, nothing happened, one day becomes a week becomes months, and then there you go, they stop the medication, and then they start feeling the symptoms. They start coming back to you like day one. Okay. Still, we're talking about lithium and its adverse effect and its significance. Now, tremor is common and typically suggests that the patient level is beyond the therapeutic level. So I gotta tell you, eyeball tremor for your patient on lithium. With tremors with tremors present, which this patient don't have before as your baseline, this patient should be flagged for should be flagged for the presence of tremor, for exhibiting tremor. Make sure when you see this patient who don't have tremors and they're on lithium, and one time you visit and then you notice tremors, that's new, I was not there before, make sure you take the lithium level immediately because they can be in their toxic level. So take it right now, So you may take it or you may refer them to your primary health care, but do something. Okay, that's a flag for you. If that would happen, you don't only want to look at the lithium level alone, but you would markedly reduce, if not stop, lithium at that point. You know, you markedly reduce, taper it, reduce it. That's your goal. Or if it's so severe, you gotta stop lithium. And not only stop and don't go back to it again. You may stop it briefly and then monitor the therapeutic level or monitor the lithium level until they become back into the therapeutic level, and then you could reestablish again in a lower dose and still closely monitor. That's just the give and take and the works of the clinician while you're putting patient on lithium. Now, another thing with lithium is that nephrotoxicity with long-term use is so evident. So you got to be very careful with lithium and kidney function. Because of a narrow therapeutic margin, risk for high concentration is also high for patients who may have some kidney insult. So you got to make sure you be careful, get some data of their kidney function, renal function, and how lithium level also should be watched and monitored closely as you relate with renal function. Because of its narrow therapeutic level, it can go so high when there's problem with the kidney. Patients subject to volume contraction are at particular. So who are these patients who may have problems with the kidney and have problems probably with volume contraction that can be very high? Those patients that are on diuretic therapy. You know, so not only that they're nephrotoxics, if they're taking medication that affects their kidney, such as your diuretic, then you would probably would notice that they can easily go into dehydration and then electrolyte imbalance. That's why you need to monitor electrolytes also. And the lithium concentration can build up easily and go into a toxic level. So that's why you got to make sure you also inform your patient that they should drink enough water like normally does and don't allow themselves to be dehydrated. Not only if they're therapeutic level, what if they are living in the southwest, you know, side of the country, Las Vegas, you know, the desert, the high desert, where they could easily get dehydrated and they're on lithium. The toxic level goes so high right away. So that's why that's another worry and concern about your lithium level. Lithium can also precipitate nephrogenic diabetes insipidus. So you got to watch also ADD. I mean, antidiuretic hormone, ADH. I'm sorry, ADH functioning, because a patient who might have diabetes insipidus can high risk for dehydration and high risk for increase of lithium toxic level. Nephrotoxicity is believed to be related to high, or to nephrotoxicity also is believed to be related to the length of use of lithium. So the longer you use lithium, the higher incidences of nephrotoxicity or renal insult. So that's the reason why you gotta make sure you monitor renal function, electrolytes of the patient. So because nephrotoxicity is believed to be related to the length of use of lithium, a lot of clinicians would also use lithium for acute mania and acute suicidality that we established earlier. And when the problem is stabilized, many of the clinicians will switch, will switch for another form of mood stabilizer. Some other people, though, you got to remember that some other people, only lithium is the only thing that can manage their mood. It just varies from individual to individual. So you got to make sure you're in tune to your patient, But you could always try the less risk there is. So still in the adverse effect of lithium, another big concern with lithium is hypothyroidism. as a consequence of iodine concentration. So where is hypothyroidism related to lithium use? Well, it is very important to understand, okay? If I have to bring you back a little bit of your pathophysiology in the endocrine system, you remember that a lot of endocrine glands, where they secrete certain hormones direct to the bloodstream into a target organ, they can also function by what we call as negative feedback loop, meaning the lack of or the more of certain hormone coming from that gland, it can stimulate its release or decrease in function. So in this case, if I have to bring you into the thyroid, you know that the thyroid functions in a negative feedback, that they produce T3 and T4. So T3 and T4 in the bloodstream, as it elevates, it shuts off the thyroid to produce T3 and T4. But not only that, aside from the concept of negative feedback, if there's too many T3 and T4, it sends message to the thyroid, stop releasing. We have too much, then it stops. But if the T3 and T4 now gets metabolized and drops down, then the negative feedback will send message to the thyroid, produce T3 and T4, we have lack. That's the negative feedback loop. Aside from that, is that a lot of your thyroid gland, not all, but some, also has what we call as the tropic hormone. So what is again tropic hormone, if you could remember? Tropic hormone are certain hormone released mostly by the pituitary, maybe the anterior or posterior pituitary, to stimulate the actual gland to produce its own hormone. In this case, for the thyroid as a hormone that produces T3 and T4 is also dependent on the tropic hormone called TSH, thyroid stimulating hormone, released by the anterior pituitary gland to stimulate the thyroid gland, also to produce T3, T4 in response to the negative feedback loop. That's where we have and tie up lithium. Lithium is high in iodine content. So with its high iodine content, you know, in your anatomy and physiology way back when, and if you could remember, iodine is an element that is really needed for the thyroid to produce T3 and T4, with it stimulated by the tropic hormone THS. So if an individual is taking lithium, which have also a high iodine content, the presence of high iodine content would naturally shut off T3 and T4, or the thyroid to produce T3 and T4. Why? If you put a lot of what is needed, its element needed for T3 and T4, naturally your thyroid would shut off and not produce T3 and T4 because there's too much thyroid, fearing that they may surge a hyperthyroidism. Does it make sense? So it would shut it off. So when it shuts off the T3 and T4, what you would notice in the laboratory, by the negative feedback loop, the anterior pituitary will increase the release of THS to stimulate T3 and T4 to be produced by the thyroid. So then you would know that as the thyroid shut off T3 and T4, the patient may manifest now the condition of hypothyroidism. And when you look at in the laboratory, there is an increase of TSH as a tropic hormone in its effort to stimulate the thyroid gland to produce T3 and T4, where in fact the production of T3 and T4 has been shut off by the thyroid because there's too much iodine in the circulation brought about by the medication lithium. So that's how the high iodine content causes a regulation of the thyroid hormone synthesis to slow down. As a result, hypothyroidism can be a side effect, an adverse effect of lithium while an individual is taking lithium. Know also that hypothyroidism can mimic and exacerbate symptom of depression. So here you are as a clinician, so you're treating them with lithium, all those cascades of physiology happens, high lithium, with a lithium management, lithium medication in the circulation, there's increased level of iodine. An increased level of iodine shuts off naturally the thyroid hormone to produce T3 and T4, fearing that too much iodine can produce a lot of T3 and T4 and create hyperthyroidism. So in its response, it would shut it off, causing hypothyroidism. Now there is decreased T3 and T4. Pituitary gland, through negative feedback mechanism, will release more TSH, trying to encourage thyroid to produce T3 and T4, yet it shuts down because there's too much iodine. Then laboratory, clinically, you would see symptoms of hypothyroidism with an increase of TSH in your laboratory, all defined hypothyroidism condition. Then the patient whose hypothyroid is low or non-functioning would manifest symptoms of depression. Then what are you going to do? Then if you don't acknowledge this physiology, chances are an inexperienced clinician may apt to think that, oh, I need to push antidepressant. Then they push antidepressant, where in fact the problem is hypothyroidism, not the mood. I want you to think that one, okay? So make sure you monitor THH level, and initially every 12 weeks upon starting of your lithium level, until also you notice some stabilization. If THS above 4, that's one thing too, is your management. If THS, that means it's above 4, so you have high THS that's coming from your anterior pituitary trying to stimulate the thyroid gland to produce T3 and T4, we could start thyroid hormone replacement, okay? Instead of just starting them with antidepressant, thinking it's the depression symptoms, it's actually a symptom of hypothyroidism, we could replace and do thyroid hormone replacement. Or you could refer them to your primary health care. If there are hypo, they may have symptoms of depression, as I've said, and you may think as a clinician that they are depressed. So this can affect your decision making and your management, that instead of giving and supporting a thyroid replacement, you may think of giving them an antidepressant. Now, why also think about the clinician's perspective of supporting the thyroid rather than stopping the lithium? Well, you know that there are individuals, it varies from patient to patient, but there are patients that still benefit the lithium. That's why you need just to support the thyroid also to decrease other symptoms of hypothyroidism. Why? Because if this patient is on acute mania, and lithium is the only one that actually controls the mania, or if not, they're suicidal too. That's priority, that's high risk. So we need to support the thyroid, cause in clinical decision that they should be on lithium, and this might be the last one that works to manage their bipolar symptom. There's no other. You probably tried other medications already. Other mood stabilizer, it doesn't work, and lithium seems to work. But when you give lithium, it causes hypothyroidism. So support hypothyroidism to control the symptoms of hypothyroid and symptoms that mimics depression, while you continue what works to control their mood. So that's just a give and take. Of course, if they will probably respond to other mood stabilizers, great. You could easily say, let's switch and not use lithium. Again, but lithium can be very effective and be the only one, the last one in the list that may work this patient. So in a clinical judgment manner, as a clinician, it's good also to consider and understand how to support this individual who have lithium as the only medication that actually effectively works, but it has also the side effect. Okay. So Let's continue with still on lithium. What are other side effects or adverse effects profile or lithium? Again, lithium may cause nausea, vomiting, and diarrhea. Neuro symptoms would also manifest and be shown when they are especially in their toxic level. So monitor their toxic level. This includes sedation, loss of coordination, decrease of recognition. Remember what I mentioned before, highlights, tremors, got to check right away. May include also decreased cognition. Weight gain is also identified with lithium uh, administration. Now, lithium is definitely contraindicated in pregnancy. So it is very important that you got to make sure you take history, especially women of productive years or women of premenopausal age, to ask about their last menstrual period. Document it before, if you think about starting lithium, document that, establish that, and also ask if they think they could be pregnant or they might be pregnant. That's another way also, is to ask about the patient about pregnancy, because lithium is contraindicated in pregnancy. Its safety in the fetus, especially in the first trimester, is not established. So that being said, when you take laboratory assessment, make sure you have enough laboratory background assessment prior to starting and at a regular interval. Prior to starting and a regular interval, you know, every month in the first 3 months and then every 6 months, about lithium level until stabilized throughout the treatment. You may also want to include laboratory assessment, and this includes your BMP, your basic metabolic panel. It has shown also to have some effect with your cholesterol, as well as your blood sugar. So you might make sure you monitor that. CBC, okay, it's also very important, is your CBC, because lithium may also decrease some of blood components such as WBC, increasing the risk for infection. Also look at sodium level, your electrolyte level and sodium level with lithium. Make sure you follow it through. We talk extensively about TSH, thyroid stimulating hormone, usually so that you indicate potential hypothyroidism. And because of that pregnancy, HCG should also be included in your panel, especially prior to starting and during management, because you don't know, the patient can be pregnant throughout the course also. So HCG is to make sure patient is not pregnant. So you gotta make sure also you include that HCG test or your pregnancy test. And then of course I cannot expound it enough, lithium level. Dosing, I think the principle here is that start low in an effective and a therapeutic range. So start low and start slow. As long as you could start in an effective and a therapeutic range should be maintained. So start low and start low. But that being said, be also mindful about your patient's symptoms. If you keep looking at the concept of start low and you are in acute mania, you are not clinically efficient. Why? Because acute mania is managed with a wide range of lithium level, and usually anywhere from 1800 milligram a day to load, with some studies initiating at 4,500 milligram a day. So, although I said start low and start slow, look at also your patient's manifestation. If they are the one, especially in bipolar 1, they are grandiose. They are so grandiose, they're probably delusional, not even. Some people who doesn't sleep because symptoms of mania is so prominent and there's not sleeping 3 to 5 days. I'm telling you, I have one patient in an acute mania who came to my clinic and was crying, and she just said, Dr. Tan, you got to do, I think I'm manic. And I said, well, tell me what makes you think you're manic. I just bought 6 80 inches TV from Sam's and Costco, and they're all on the road to delivery on top of the jet ski that I bought also all today, and it's soon to be delivered in the marina at Lake Mead. I think I'm manic, and I said, I think you are, you know. So patients who have those, remember, start slow, and start slow might not be a good effective thoughts, you know, but generally be very careful, especially when coming from out of mania and you want now to maintain because acute symptom has been controlled, then you could apply that principle really well for safety. Another example of an acute manic phase that I can share with you as a clinician is I have a patient who came over and said, I think I'm very manic. And I said, what makes you think you're manic? It's like, I didn't sleep for the past 3 days, and last night was my third night that I'm not sleeping. I have all the energy. I gamble, and I gamble a lot. And after I I gamble all my money and blow up my credit card. In gambling, I went on bench drinking, and that's when I met a lot of people that I don't know. And then I end up the day and the night with multiple sex partner. And I think there's about 8 people that I have sexual activity with. And she says, what's really weird is when I was doing it, I'm not even vincodistant with her. It's both mix of male and female, and all of those happen all at night. So that's why I came over. You could just see how extreme the acute mania is. So in that case, you could use the range between 1800 to 4500, you know. But make sure know that that is not the maintenance dose. That is just for your acute mania. Maintenance dose typically is around 900 to 1,200 milligrams per day. That's when you start thinking about, then convert it when you control the acute symptoms in a lower dose and increasing it slowly. So when you treat acute mania and low at 900 a day, think that it's not appropriate too, you know. In acute mania, at least you have about 2 times of that. It's what's needed for that acute mania stage. So try to make that clinical decision. Okay, so this time we're gonna go into anticonvulsants. So anticonvulsants are a group of medication. Some books will call it anti-epileptic drugs. Your book call it and refer this as an anticonvulsant. So I will use the word anticonvulsant to be consistent with your Styles book. So we refer to that one. This is another group of medication that is primarily ordered for epilepsy or convulsion, but has and been found out to have some effect in mood stabilization. Well, the background perhaps is that this group of medication all targets basically the same neurotransmitter, primarily the GABA, the glutamate, but there is significant variability between them. So talking about, again, if you remember, you know, glutamate is the primary excitatory neurotransmitter in the brain. So therefore, if your anticonvulsant primarily targets and mediates GABA and glutamate, then the excitatory effect of glutamate that may support why the patient becomes manic can be toned down and controlled with anticonvulsants. And that's the whole reason why, you know, anticonvulsant can be effective in treating your bipolar patient. The same with GABA. You know, GABA is the primary inhibitory for central nervous system. Your anticonvulsant can mediate, you know, and potentiate the effect of GABA to come down while controls the glutamate, which is the excitatory. So it may enhance GABA's natural potential while it controls the glutamate excitatory function. So that's how it's very useful. So anticonvulsants are designed to suppress excitation in the central nervous system. That's in the case of that is the case of glutamate, right? And then suppresses, so that's in the case of enhancing GABA's function. So anticonvulsant blocks the action of glutamate and potentiates the action of GABA. So some anticonvulsant can potentiate and manage bipolar symptoms, while other anticonvulsant has no utility to manage mood at all. I just want to let you know. That's why there are only few anticonvulsants that are used to manage behavior, controlling your glutamate and enhancing the effect of GABA to control the mood and the behavior of an individual. Well, there are anticonvulsants that are not considered mood stabilizer because they just do not find out to have any influence in controlling mood at all. And in that case, don't have any influence in bipolar disorder. So in this discussion, we are only focusing on those anticonvulsants that has some influence in controlling mood swings in a bipolar patient. So also I want you to understand that there are some anticonvulsants that are manic-minded and some other anticonvulsants are depression-minded, meaning that they are anticonvulsants, yes, but they control from the top, which is your manic symptoms, and there are also that anticonvulsants that are very good for symptoms that the major symptoms of bipolar is depression. So they manage from the below or from the bottom, which is the depression-minded minded medication. As I've said, others have no clear utility at all as it in mood stabilization. So let's talk about those anticonvulsants that treat from above, those anticonvulsants that manage from the manic perspective or from manic symptoms. There are two anticonvulsants that have clear demonstrated utility in treating acute mania and providing stability. So now you have a picture while lithium also controlled from the top, which is your acute mania. You have other alternatives, your valproic acid and carbamazepine. In that case, Depakote and your Tegretol in the brand name are also anticonvulsants that demonstrate utility treating acute mania from the top going down. So valproic acid is preferred to use in treating bipolar above or treating bipolar from above or with manic symptoms than lithium due to safety. Due to safety. Know that lithium has a very narrow therapeutic level, and you have now an alternative for valproic acid perhaps that it can treat also the same. So why not use this? But why use lithium too sometimes? Well, that is now your clinical decision making, because usually valproic acid, although still have some therapeutic level to maintain, its MEC and MTC, your effective concentration and your toxic concentration, is more wider. So you have more of safety precaution there. But remember, what did I say? What you gain in safety, you lose in efficacy. So probably valproic acid is a good symptom or a good alternate medication after you control the acute manic phase with lithium, and then you don't want to continue lithium because of its risk and therapeutic narrow therapeutic level and toxic level, that then although the patient still has some manic episode, not the acute now, then you switch to valproic acid. So that's how you make decision now. You may probably switch them after controlling with lithium. Okay. Carbamazepine is another type of that medication. Both valproic acid and carbamazepine also have therapeutic level, but as I've said, they are wider. Both don't have the lithium effectiveness to decrease suicidality. So that's another thing. You may have a patient who's an acute mania and they have suicidal ideation. Well, valproic acid and carbamazepine doesn't have that characteristic to control suicidal ideation. So that could be a reason why you would like to initiate with lithium and then along the way decrease the lithium or perhaps switch to valproic acid and carbamazepine, because of its effectiveness and safety. But not all patients also have suicidal thoughts. You got to remember that, okay? So not all patients should be probably a candidate with lithium. So that's when you could play now your decision making. Just make a risk-benefit decision, You know, make a risk and benefit analysis, and you put them all together, and finally support your assessment and your impression with an effective clinical decision as to what medication you want to use. As I've said, valproic acid is manic minded. This is the single most important anticonvulsant to stabilize mania. So again, your valproic acid is manic-minded, and this is a single most important anticonvulsant that can stabilize mania, although it's not as effective as lithium, but at least it's safer than lithium. So if you cannot use lithium, this is the one to use. You know why? Because your, as I've said, your valproic acid can potentiate GABA. So it can potentiate the effect of GABA, that it can slow down, calm down an individual. Its potential to be used in the up mood by potentiating GABA and inhibitory, so it controls the up mood and up behavior of a patient who has bipolar. It controls mania, and it can have some long-term stabilization context and effect. Although the other part of your valproic acid is that its efficacy for depression side is not so clear. I'm not saying it's not there, but it's not so clear. It's not as prominent as its manic control. So, you know, if you have a patient who's bipolar, no suicidal ideation, but exhibits manic symptoms more than depressed, so probably valproic acid is a good choice for your carbamazepine. Okay? Again, it is generally considered safer than your lithium. So as I've said, you know, valproic acid is manic-minded and the best anticonvulsant for stabilizing manic mood. And various mechanisms of action are theorized here, one of which is that it potentiates GABA. Is one of its more common reasons why it can control the up mood of an individual. It is used also for both control of acute mania and long-term stabilization, but its efficacy for depressive episode is unclear. Like many older mood stabilizer, you need to be vigilant with monitoring the side effect profile with your valproic acid and its level also. So what are some safety adverse effect consideration you got to remember? It is contraindicated in pregnancy. Again, just like your lithium. So therefore, you got to check history of potentially be pregnant. Are they in their premenopausal stage or their productive years? They're contraindicated in pregnancy, especially in the first trimester. They can be hepatotoxic. So they can be hepatotoxic. They can hepatotoxicity because they can cause hepatic necrosis. So it's very important for you also to get a baseline liver panel profile, such as your SGPT, SGOT. You know that you got to look at liver enzymes. They are also, valproic acid is also identified to cause pancreatitis. Now, hyperandrogenism is also a concern. So in women, so therefore this might not be a good choice if you have a patient with PCOS. What's PCOS? Your polycystic ovarian syndrome. It has strongly related, your PCOS has a strong relationship with your androgen, because your PCOS is a condition in which the ovaries produce an abnormal amount of androgen. Okay? It is a male sex hormone that are usually present in women in small amount. But with PCOS, your polycystic ovarian syndrome, the individual here produce an increase or abnormally amount of androgen. And thus, if valproic acid can precipitate hyperandrogenism, then you got to be very careful to get a good history that this individual don't have PCOS prior to initiating valproic acid to control their behavior. There are metabolic risks also, just like with any other mood stabilizer. Your lipid panel, you should watch your your blood sugar, hemoglobin A1C should also be considered as a baseline that you check prior to valproic acid administration. And then valproic acid is known also as of its sedative effect. It has some sedation as its side effect. Then that's the valproic acid. In carbamazepine, this is the only other anticonvulsant that treats from above. So aside from your Depakote, Depakane, or valproic acid, your carbamazepine or Tegretol also treats symptoms of mania. But its mechanism of action is different and is not fully understood. It's just known that its efficacy may also achieve the outcome of controlling mood swings, especially that of mania among bipolar individuals. Subsequently, there are some different uses and adverse effect and concern of your carbamazepine. So what are some of the adverse effects that is cautioned while using carbamazepine? Again, it's contraindicated in pregnancy. So the same as your laboratory tests, history, last menstrual period assessment is needed. It can have some sedation, and also it has strong hepatic and pancreatic concern. It exists. Okay. So still on your carbamazepine, what are some unique concern? One of the unique concern of your carbamazepine is agranulocytosis and also aplastic anemia. So agranulocytosis can happen very fast while the patient is on carbamazepine. So you got to make sure you educate the patient about infection, that they need to come to you or to the PCP. Make sure you do this health education and document that you did, PCP, and to inform that they are on carbamazepine. So even a simple a sore throat, if they are on carbamazepine and they develop sore throat, that is good enough indication to inform the provider of the occurrence of that infection. So upper respiratory infection, UTI, even simple infection, you got to make sure that you tell them to report to your primary care or your primary care provider. It needs to counsel the patient regarding acute onset and infection symptoms is what we're coming from. Another thing is that carbamazepine is a CYP450 inducer. So what do you mean by CYP450 inducer, especially the allele of 3A4, But as an inducer to 450, if you remember your pharmacokinetics, also, your CYP450 is a way of how the body, it's the gene that actually would metabolize, simplify, and excrete that chemical out. Well, your carbamazepine is an inducer, so therefore it can increase metabolism and excretion of certain chemical or certain substances, even its own. So carbamazepine is an inducer of the CYP450, so they induce metabolism of other medication. So it can induce its own metabolism even. So it metabolizes itself. So you go higher and higher in dose, and Tegretol level or carbamazepine level might keep going low. So why? Then you ask why. We increase the dose, and then the level goes down and goes down. It's because it is an inducer to medication other medication even to itself. So also be very particular that if you're giving carbamazepine as an inducer to CYP450, other levels of certain other medication might go down. So you need probably to adjust medications, that they are also currently taking, you know, that that can be affected by the inducer effect of carbamazepine at the CYP450. So make sure you look at all this medication, if what's their effect along with carbamazepine, especially when you are in your anticoagulant, when you're into anticoagulant or probably medication that affects the heart, that has certain level also, you might be considering reviewing them as to how it can potentiate increase in metabolism. Even its own carbamazepine metabolism can be enhanced. So you need to have higher level to maintain a therapeutic effect. So make sure, so level needs to be followed up. Remember, it can metabolize its own. So laboratory assessment at baseline, you would like to look at valproic acid and carbamazepine. Make sure you order CBC, and that especially your white blood count. Of course, you look at it. Liver function test, because it can affect, of course, it's contraindicated in pregnancy. So you look at HCT, look at electrolytes. Also consider HLA testing for high-risk patient. What is HLA testing? HLA stands for human leukocyte antigen. Human leukocyte antigen testing. Why? Human leukocyte antigen testing, or human leukocyte antigen, is in the surface of the cell of a tissue, and it is used to match, normally is used to match transplant recipient, transplant recipient. So that's why you want to make sure to look at its effect. Also is somehow related to patients that are on carbamazepine at toxic level, may cause your let me see. Yeah, it may cause the development also of toxic epidermal necrolysis, or TEN. So because you want to test your HLA testing for high-risk patient, and they are the antigen that's attached to normal cell, it may react because it may lead to the toxic effect, may lead to your toxic epidermal necrolysis, or TEN. It is a life-threatening skin disorder characterized by blistering and peeling of the skin. This disorder can be caused by drug reaction to carbamazepine, to carbamazepine, and often due to antibiotic and if not anticonvulsives, which is carbamazepine is one of that. Now, Asian are high risk. Asian descent can be high risk. So you could see there in the drawing or in the picture that includes generalized blistering, and it is life-threatening, that it can be, patient here is intubated and may even cause death. It's generalized blistering. Somehow it's related to Stevens-Johnson syndrome, but I gotta tell you, Stevens-Johnson syndrome may have some minor blistering, but it could be generalized rash. Is Stevens-Johnson, so it's 10 times. So I would say your toxic epidermal necrolysis is a Stevens-Johnson syndrome times 10 in steroids. So make sure you incorporate HLA testing for high-risk patient. Another one is your pancreatic enzymes as indicated. Gotta make sure, because it can affect pancreatitis too. So ongoing lab assessment, you would like to continue getting CBC and electrolyte at least 1 to 2 weeks after the start and after the dose changes. Then periodically as indicated. LFT, liver function tests, can be done monthly for the first 3 months while on this medication, and then drug levels about 3 to 4 weeks after the dose is being adjusted. That will be a good practice or standard practice, a benchmark laboratory assessment for your carbamazepine. Lab assessment for valproic acid, your liver function test, and monthly for the first month. And then after stable, your liver function test and CBC monthly can be taken until mood is stable, and also, of course, dosage is more stable. Drug level usually 3 to 4 weeks after changes, usually a minimum of every 6 months when stable is also standard good practice. Others as indicated when concerns exist, such as your pancreatic enzymes. Treatment from other anticonvulsant. Okay, so treatment from other anticonvulsant, one of which another medication, another anticonvulsant that is considered, another lamotrigine is another medication in the classification of anticonvulsant that has some benefit in mood stabilization and management. This is approved to prevent both mania and depression. That's the advantage of lamotrigine. Although its mechanism of action is different from other anticonvulsant, it's basically lamotrigine does its job by blocking glutamate action, which is your excitatory. Okay, so lamictal is the first drug commonly used in bipolar depression. It blocks the glutamate action, as I've said, and this managed from below, not from manic symptoms. So it can control your it can control bipolar, specifically those individual that has depression as its main feature in their bipolar. This has become the first line of drug for bipolar depression also. So this is more safer than the more safer symptom control. Although the problem is that, although safer, its symptom control is not so profound. Again, it follows that principle what I say, that what you gain in safety, you lose in efficacy. But at least lamotrigine or lamictal is known to control symptoms of coming from depression going up. For patient who seems to be depressed but may have possible bipolar issue, or for patient who could be mood disorder not specifically specified, remember that gray area, you cannot identify they have unipolar depression or bipolar disorder, but they manifest mostly depressed with some periods, occasional, seldom, having some hypomania, and that pictures bipolar 2 criteria. Lamotrigine can be a choice that you can make. It is not FDA approved for either bipolar mania or depression, but clinically it is frequently used for bipolar depression type. It is also commonly used for mild hypomanic symptoms. So that's why you have the bipolar 2 picture. But unlike your valproic acid and carbamazepine, it is not effective for acute mania. So your lamotrigine is not so effective in controlling your acute mania, but that of the depressed side. Its side effects profile is better than the preceding mood stabilizer. Adverse effects, so it's safer, although its primary adverse effect concern is the generalized pruritic rash. Sometimes, that's why this medication sometimes is called as lamictal, the itch, lamictal, because its side effect, to warn you, is the pruritic rash, which is basically rare, but potential extension of this is your Stevens-Johnson syndrome. So you have rashes, generalized rash, unlike your the other one in carbamazepine that has blister and peeling off, you know. So Stevens-Johnson can be very common. So you got to make sure you talk to your patient about this, that if they would notice general rash, to stop the medication right away. Usually your lamotrigine is very, very slow to build up. It's given 25 milligrams once a day for 2 weeks before you increase it to 50 milligrams once a day. And it could now go to the range of up to 200 milligrams twice a day. But you need to make sure you taper it up very slowly, watching for symptoms and side effects, especially Stevens-Johnson syndrome. And usually increase 50 milligrams per every 2 weeks. And that's how you taper up lamotrigine. Uh, let's talk a little bit more about lamotrigine. Um, Again, aside from its Stevens-Johnson syndrome, which is milder than your TEN, Stevens-Johnson syndrome, remember, is a rare serious disorder of the skin and mucous membrane, and it's usually a reaction to medication that starts with a flu-like symptoms and followed by painful rash that spreads on and may develop blister. And then the top layer of the affected skin dies and sheds off, and healing begins after several days. So that's your Stevens-Johnson syndrome. Lamotrigine 2, although it's really good, I mean, it can create and control the depression part, usually it's not as pronounced in its effect. So sometimes it can be, although it can be used in your bipolar 2 kind of top, this can be an adjunct or adjuvant medication with other mood stabilizer. Like, for example, risperidone perhaps, as an antipsychotic, and then lower dose can be used as a mood stabilizer. We'll talk about that later on under antipsychotics. But your lamotrigine can be a good complement to it. Lamotrigine also can be complementary with your lithium or valproic acid. You know that there's some combination, but it is meant to decrease or the possibility of keep increasing a more potential dangerous type of medication. So its presence can be an adjuvant to a medication to enhance its effect rather than keep increasing the medication that has high risk profile. Instead of keep increasing the lithium because it can impact in the therapeutic level, it has some side effects that are not, that are not safe, then you may complement it with lamictal so that you don't keep increasing your lithium in that manner. Other anticonvulsant, do you have oxcarbazepine or trileptal? It's another anticonvulsant medication. Trileptal is a molecular twist, by the way, of your carbamazepine. So that's why it's also called oxcarbazepine. It's a better tolerated than carbamazepine, so frequently tried off-label to control symptoms. Although there's no clear evidence to support its use for bipolar, some clinicians use trileptal because it can make some difference, although it's not clear as to its mechanism of action. Generally thought to confer some improvement from above. So being a twist from carbamazepine, like your carbamazepine, this can be an alternative to be used to treat your acute bipolar symptoms. Topiramate. I think some of you hear this, or Topamax, topiramate. Topiramate, like trileptal and Topamax can be used after you stabilize someone and you want to maintain them with less toxic drugs. Then this can be your choice, is your Topamax, okay? The advantage here is a link for weight loss, unlike other of your psychiatric drug that may have a profile of weight gain. Topamax is also used off-label by a lot of primary care to lose weight, and it has lose weight. Normally, generally considered anticonvulsant, but they use it also for migraine. But a lot of clinicians, although there is no direct impact on mood, still use this because they may see some improvement. It has a unique property that it has the adverse effect of weight loss. So that's why some people would like this for weight loss purposes. Now, this can be used in conjunction with other mood stabilizer, as I've said, to decrease the stabilize someone and decrease the toxic level or potential toxic level. It can offer synergistic effect also to other or mood stabilizers. The side effect profile is related to cognitive blunting, okay, leading to its nickname Dopamax. You know, they said that when you take Dopamax, it has some. I've heard that from a lot of my patients who on to Dopamax because of weight loss property that they prefer over other anti mood stabilizer, but they would say it blunts their thoughts, their thinking, their memories, and they're like kind of dopey. You know, they're dopey, so that's why they sometimes nickname it as Dopamax. Okay. Other anticonvulsants further, you have your gabapentin and your pregabalin, and that's your Lyrica, gabapentin, or your what's the brand name of the gabapentin? Anyway, gabapentin is a generic, and the pregabalin, which is brand name Lyrica. Again, you know, a lot of clinician uses this also to stabilize mood and perhaps to decrease anxiety symptoms, along with mood disorder or along with your bipolar disorder. A lot of patients who are bipolar also have some anxiety, they have mood swings, they have anxiety, so gabapentin can be, because it can have some effect to your anxiety symptoms as a comorbidity as it stabilizes the mood, although there's no evidence to support their use as a mood stabilizer, but can show benefit in comorbid anxiety symptoms with mood disorder. Now, another advantage of your gabapentin and Lyrica, although used as an anticonvulsant, controls anxiety, some symptoms of anxiety. It is also used sometimes as patient's medication regimen for comorbid anxiety and neutropathic pain or neurogenic pain. So a lot of patients who are in back pain, you know, certain neuropathic pain, and then develops anxiety, and they also have mood disorder, may benefit out from your gabapentin as your choice. But they are not first line. You know, you could use them then after other trials of other first line medication indication has been utilized, and then sometimes as an adjuvant medication. Now let's go to your antipsychotics. Okay. So although antipsychotics, I want you to understand that although antipsychotics has its own indication, which is psychosis, and we will be able to discuss this further in detail in the next discussion for antipsychotics, but we're still in mood disorder. I want you to understand that the utilization of antipsychotics for mood stabilization can also be dependent on low of different dosing. So although one medication is there, I always tell this to my patient. If I use this medication, it's classified as antipsychotic. I don't want you to think that I'm diagnosing you with psychosis, but I'm using this class of medication because it has its benefit to mood stabilization in certain dose, and mostly in a lower dose, you know. So if you use a certain antipsychotic like risperidone perhaps, the use of risperidone at 0.25, 0.50 to 1 milligram mostly has some benefit to mood stabilization as well as symptoms of agitation and anger, while the use of risperidone at 2, 3, 4, 5, 6 milligrams is very highly indicated for psychosis. So that's one thing that you can tell your patient about. Okay, that you could use antipsychotic, but you're adjusting the dose, that it can have its impact on mood stabilization, and that's where I'm coming from. Several atypical antipsychotic have some levels of indication for bipolar disorder, and usually lower level. Theories on applicable mechanism of action are all over the place and not well defined. And you will just find out again. You have your physiologists who study this and who's not so clear how it works, but you have also the evidence-based practice clinicians who observes the use of this medication has an impact in controlling the symptoms you would like to control. So generally, doses are lower when used as a mood stabilizer when you come to your antipsychotics. So let's talk about risperidone. Risperidone, brand name Risperdal, is indicated for short-term use of mania. So it has indication for short-term use of mania. And you got to know over time also the characteristic. You know, just like when we talk about lithium, it's good from the top, it's good from acute mania, it's good for suicidal case. We talk about carbamazepine and carbamazepine, Tegretol, or valproic acid. They control from the top. And we talk about lamictal, they control from depression symptoms. There are other also medication that has its unique feature in controlling certain aspect of bipolar symptoms. In this case, risperidone is good for mania, but what's more in mania about risperidone is that risperidone is good to control the agitation and the anger. So if you have a patient who are hypomania, they have mania, they can easily be very angry, enraged, they throw things, they punch hole in the wall. Risperidone in a lower dose to control that hyperactiveness manic phase, especially anger and agitation, is a good choice. You know, of course, it's not good for everyone, but that's something to go by. Frequently used for management of bipolar 2 due to its irritability, especially symptoms of quick to anger, is a prominent feature of your risperidone again. You know, a lower dose is used for mood disorder, are typically better tolerated than higher doses that's used for your psychotic disorder because it could have some all its own risk profile. Of course, I will not be talking about too detailed into this all medication. You probably would hear them back again when they are discussed back again in the context of their classification, which is antipsychotic medication. But right now, I'm discussing this antipsychotic in the realm of mood stabilization. Otherwise, there's nothing to discuss about the next time we have. But I'll focus on the dose upon which they're used for as a mood stabilizer. It is an old, yes, it's true, it's an old and expensive medication, and may a lot of insurers require to try it first. So that's one thing too that you have to you have also to consider in your clinical practice. You know that costs, medical costs, is also one of a compliance issue for the patient. So there are a lot of insurer that would say use this first. There's the first line. It's cheap. It's old. It's proven. That's what we're gonna approve. And then if you would document failure of the medication to control the symptoms, then we will approve another tier. That's another common concept that has to be incorporated in your decision making in prescribing and management, especially that of mood disorder. So you might make sure to consider this as your first step. It depends on your insurance. Adverse effect profile common to many older antipsychotic, though, is that it can affect metabolic consequences. Again, your profile, lipid, cholesterol, hemoglobin A1C can affect this, hyperlipidemia. Another very another very prominent feature of your risperidone is hyperprolactinemia. So make sure, especially among boys of adolescent, if you start this on, make sure you monitor, and in fact, both sexes even, make sure you monitor the prolactin level. Prolactin can also, an increase in prolactin can also stimulate production of discharges in the breasts. And if you notice that in the biologic basis for mental health, biologic basis theories, you would know that even parts of the brain, parts of the brain that controls prolactin level can be stimulated by some neurotransmitter, and then it can increase your prolactin level, and that's how it affects. So ask gynecomastia, make sure you monitor, and then adjust your dose, taper it down until, make sure you know the normal prolactin level reference. Make sure you read your book for that and know about that. And the decision making is to decrease and taper it down, if not stop and change it, and look at risk versus benefit, especially with young adolescent male, because they might have some gynecomastia, which is very or which can affect their body image. Sedation is not so much, but it can have some effect. That's why it's usually be given at bedtime so that they could also rest and sleep. And it has known some GI effect. Nausea, vomiting, dry mouth can also be very common here. There's another antipsychotic or atypical antipsychotic. It's your aripiprazole, or also marketed as your Abilify. Aripiprazole is a newer than risperidone, so it has some lesser side effect profile, much better. It's indicated for also mania, for bipolar disorder, typically with other mood stabilizers. So this is a mood stabilizer. Recently, also your aripiprazole has some indication for depression. So next one, so usually your aripiprazole can be approved by insurers after you try to use Risperidol. If it's failed, then they will approve aripiprazole, or after Risperidol or Seroquel fails. We'll talk about Seroquel later on. Typically, not use as a monotherapy, but it can be. It has a minimal side effects also than your older antipsychotics. Cariprazine, or also known as Vraylar, is fairly new medication. I do have a lot of good experience with Vraylar as an antipsychotic mood stabilizer. But the problem is it's new. It's used as brand name and very limited coverage or full coverage for any insurer. Its newer antipsychotic marketed as Vraylar. Its claim to fame as it does not produce significant weight gain. That's an advantage. And also, its claim says that it has a very minimal impact on metabolic problems. So hemoglobin A1C, it doesn't usually increase it, or cholesterol and lipids. The problem is coverage right now. So it has its own indication. Then you have another antipsychotic that can be used with bipolar depression is your quetiapine or Seroquel. Depending on the dose that you give it, it can have a different effects to people. So it can have different doses to people. This has only this is the only antipsychotic that has street value. So I have to tell you, your books mentioned that, and this is the only antipsychotic that has a street value. What do you mean by street value? That they are sold in the market. Also, although they are not controlled and they are not addictive, because it has some effect of calming down, well, people who actually use meth, cocaine, that stimulates their dopamine and excites them, and they're awake for days, partying, lots of energy. In order for them to calm down after 2-3 days of partying, and they're exhausted, but their mind keeps going and they cannot shut it down because still of the effect of dopamine overload, or perhaps still the excitatory effect of the drugs that they're using, as again as crystal meth, then that's why it has a street value, that people buys them to help them relax, sleep, and get the needed relaxation after nights and days of partying using drugs. So that's why it has a street value. Usually 50 to 200 is used for sedation. So if you have a symptoms of bipolar where they're not sleeping, they're starting to have hallucination, this would be a good choice, so that it promotes them sleep. Now, one thing you need to know about your Seroquel, its initial impact is extreme drowsiness. You need to tell the patient to take them. And some of them would say, I would not wanting to, I take it once, twice, 3 times the first week. I was so tired. That's true. But that will not stay too long. If they continue taking the medication into the second, third week, then sleep starts to regulate. They will not be as sleepy as they are in the first few days and week of taking the medication. They need to get over the hump. That's one thing with Seroquel. Um, it has all of the typical adverse effect concern of the older antipsychotic also. One of which I've seen a lot with Seroquel problem is weight gain. Metabolic syndrome is very prominent, so increase in him H1A, blood sugar, lipids can be present in your Seroquel. But for people who use it for symptoms such as not able to sleep, having insomnia, because of their bipolar, Seroquel could be a choice. And then you could decrease and adjust and move after the acute phase if need so. But it has its own effect. Recently also, not recently, but if I would say 5 to 200 lower dose is good for sedation, mid dose around 100 to 400 can be also indicated for depression effect. In fact, it has a good indication for antidepressant or depressive type of bipolar. So Seroquel can be a choice there. And it has an indication up to 800 milligrams. It has a very wide range from 50 milligrams to 800 milligrams. But a higher dose of up to 800 is effective for antipsychotics. 600, I've seen 600, 800 are effective antipsychotic. This is a good medication also as an adjunct medication for unipolar depression. So it's an adjunct medication to unipolar depression and effective for bipolar symptoms, which mostly depressed as well. So people who have resistant unipolar depression, of course, not a first line. Your first line is your SSRIs, but if those fails, then you could use this as an adjuvant and add-on medication as an antidepressant. Another antipsychotic medication, bipolar depression kind of thing, is Latuda. Lurasidone is comparatively newer within the 10 years. It has a good indication also as an antipsychotic, but I have also seen a good result in mood stabilization with Latuda. It has side effects that are lesser risk and is better tolerated, is better tolerated. Has been approved for bipolar depression type like your Seroquel for several years now. And this has a really good profile with your laboratory. It does not increase your weight. It does not increase so much of your A1C, and your metabolic panels will not be affected a lot with the Latuda. I have good results, as I've said. I think it's coming up this year for generic. Not necessarily it becomes cheaper, but it's still expensive, and a few years after it becomes generic is when you could feel the impact. But insurance has a problem with the coverage. But I've seen a good result, especially with, we'll discuss it later on about its antipsychotic properties. But as a mood stabilizer, I also can assert with this medication. It's just the coverage is my problem. This is now approved for unipolar depression as well, just like your Seroquel. So they're trying to have it as an antipsychotic. It becomes a mood stabilizer, and then it becomes also indicated for unipolar depression. Of course, not as a first line, but as an alternative, and it does good its job. It varies from 20, 40, 60, 90 to 120 milligrams a day. So, in a nutshell, so those are your most common medication to treat antibipolar. So, selecting therapeutic options here. Very important, I would like to let you know that patients should be evaluated appropriately so that you will come up with a very strong, supportive, clinically supported by symptoms and evaluation before you come up with your diagnosis. So proper diagnosis is very important before you decide on which medication to use. Again, don't focus only, although your first step should be the patient's chief complaint, expand it. Ask especially what I call pertinent negatives. So I don't know if you talk about pertinent negatives in your clinical interview skill. It is one of a very good skills that you could adapt is to get the pertinent negatives. What will be the pertinent negatives? Although the patient tells you how depressed they are, you would like to ask some other, like your review of system, to catch what they probably experience that they don't consider priority, but they experience it and they cannot remember unless you ask them. So ask about pertinent negatives too. Although they will come up with anxiety or depression, ask about mood swings. You ever had mood swings? And then you document as denies mood swings. Of course, safety and the pertinent negative plays a part of it too, such as, do you have any thoughts of killing yourself or others? They might not be telling you that, but unless you ask, they say, then pertinent negatives, documenting it, you probably say denies anxiety. I mean, denies suicide, denies homicide. Ask extra to get a big picture and to strengthen your diagnosis. you know so when you do that, do not miss asking also medication they have trailed around. You got to remember that this patient came to you and probably it's the first time you met them, but they have been on psychiatric treatment on various providers. So ask them about their medication. What have you experienced or what have you used before? And those that you could remember, some of them cannot, describe to me what's the effect or the side effect. Why did you stop it? For what reason? Some of them might be so very dramatic because of the side effect and they stop it, so probably you indicate you're not go there. But some of them would tell you that they've tried it, it has a good result, but they have to stop it because their insurance changed or they lost their job, and coverage is not, and they cannot afford, they stop it. It will be a good way to go back. Even extend it to family. Do you have any families that have, when your discussion about family history, and then they probably, do you know any medication that works? Because chances are they have the same genetically, and what works with one family member might be a good indication to try. So trail the medication, both their history and if not with their blood relation. Review meds history is what I'm coming from, and what has helped and why they stop it, and equally important with what has not worked and what was the result. As always, ensure right diagnosis, and we talk about that. Start simple when able, and not all bipolar cases are complicated, and that's really true. Do not think that all bipolar are complicated. Some of them are very, very straightforward symptoms, and then you could identify, look at their symptoms. What are their general characteristics? Are they mostly depressed? Are they mostly manic? Then you should have your choice now. What are the mood stabilizer indicated for this? As a mood stabilizer and it's mostly mania, then you're probably looking at your antidepressant, antipsychotic, mood stabilizer, adjusting the dose, or they could be mostly depressed, they could be mostly angry, they're not sleeping. So try to ask those symptoms and try to equate them into your knowledge of the medication indicated for this diagnosis. So make sure you have the right diagnosis, and you get the right diagnosis by expanding your history and asking more symptoms that may not be readily presented to you by your patient. Acute manic patient, consider degree and control of mania, and then consider the need for acute mania, acute manic control, and then switching it to a less risk type of medication. So that goes with lithium, valproic acid as your indication. Now, mild mania may respond to monotherapy, but one thing, especially when they have mania, avoid antidepressant at this point. Antidepressant can make them more hyperactive and manic. Also, even in your mood stable, even with your mood disorders and your bipolar, especially when you have symptoms, don't start them with antidepressant right away. Mood stabilizers, make sure you document symptoms and why you started them on. Some milder mood stabilizer, lamotrigine, can be done, or some atypical antipsychotic in a lower dose can also be a choice that you can. There are patients that are more complex, that mood stabilizer alone or monotherapy may not be the only way to go or the only way to control their symptoms. So then also anticipate that combination therapy can be done. A combination therapy can be a combination of your atypical antipsychotic mixed with lithium or with valproic acid. Starts low dose and slow, but you could start mixing them up, to control more symptoms. Any combination of lithium, valproic acid, and lamotrigine, or can be combined, any of those, or the three of them can be also be potential. There could also be a combination of lamotrigine with quetiapine. You notice I told you in lamotrigine, they can be a good adjuvant to other adjuvant to other mood stabilizer, or in that case, atypical antipsychotic that is used as your mood stabilizer by adjusting the dose. So they can be combined. So think about that could be your option also. Very interesting is that your book also identifies geographic combination that you could go by, after you know the basic of this medication, then you could go depending on the symptoms and control of symptoms of the patient that over time also, then you could adapt some of the principles here. So one of which is the Boston Bipolar Brew. So when we say selecting therapeutic options by virtue of geographic combination, so there's probably this geographic combinations has been tested and been used mostly by these clinicians in this area, and they're willing to share their thoughts. So these are just some options that you could go by. So when I say Boston Bipolar Brew, this is made up of the thought that any combination of mood stabilizers and antipsychotics, except no antidepressant. So you could have lithium, lamictal, valproic acid combined, mix, match along with your antipsychotic perhaps, Abilify or Risperidone if they have anger, agitation, or a little of Seroquel if they're not sleeping at the same time but they have some acute mania, so if Seroquel and lithium, and then mix with a little lamictal because of depression, but no antidepressant. That's your Boston Bipolar Brew. Your California cocktail is any combination of your mood stabilizers and your atypical antipsychotic, but this time you add an antidepressant. This is a prominent feature. Like for example, if depression is a prominent feature of bipolar symptoms, and you add a little dose, not the full dose, as it's indicated as a unipolar medication, of your antidepressants. So these are the medications now that you probably have a Risperidone and then mixed with little lamictal, but then you still have the symptoms of depression, but instead of putting 20 milligrams of Prozac, then you may try 10 milligrams of Prozac. Or instead of 20 milligrams of Lexapro, then you give 10 milligrams of Lexapro. So lower the dose, but with the presence of antidepressants along with your mood stabilizer is your California cocktail. And then you have your Tennessee Mood Shine. Well, in Tennessee Mood Shine, they describe it as an atypical antipsychotic and an antidepressant, is being mixed. There are depressive mood that are more identified, so then you mix it with antidepressant with some atypical antipsychotic. Not just mood stabilizer, but it's antipsychotic along with your antidepressant is your Tennessee Mood Shine. While your California cocktail is a combination of antidepressant along with your combination of your mood stabilizer and antipsychotic. But your Boston Bipolar Brew is a combination of mood stabilizer and antipsychotic without antidepressant. So any of those principle has been well established, but you got to make sure that you start low and you start slow as it's appropriate to control the symptoms you're managing. But so don't just mix them up all at once. Take one step at a time. Give it time and for your observation, and then proceed from there. Okay, so that ends our discussion with your mood stabilization. I will get back then, and this time we will be talking next time about your psychotic disorder. Thank you so much.